Hello, I am Dr. PLL Kapadi, Senior Interventional Cardiologist from Care Hospitals, Banjarais. Today, I want to show a case of Rota made easy with my experiences with Rota Pro cases. So, as we know, the calcium is a growing problem that negatively impact the PCI if it is left untreated, and it is more prevalent in patients undergoing angioplasty. And calcium leads to mm, worse clinical outcomes, and calcium can inhibit the optimal stenting also. And now the rotapro is a recent thing which modifies the plaque, and so that the lesion modification is more important for the making the calcific lesions angioplasty simpler. And the complications due to calcium occur pre-angioplasty also because of the dissections with naive balloon angioplasty, and difficult also occurs when there is a dilatation occur. And during peri-procedural, what happens is there is inhibitions the balloon expansion, and balloon crossability also becomes difficult, and sometimes the stent expansion, stent malappositions can occur. And especially post-angioplasty, without any lesion preparation, there is insufficient expansion as well as malapposition, which leads to stent thrombosis as well as the stent restenosis rates. And the key benefits of this rotablation is, especially with RotaPro, it will minimize the vessel trauma and enables the lesion access as well as facilitates the stent delivery system, optimizes the uniform stent apposition as well as the expansion, and creates a large minimal luminal diameter, and it avoids the rota regret also. And especially the rota regret, if you can do the naive balloon angioplasty without lesion preparation, the both balloon crossability become difficult and balloon expansion also become difficult. Suppose if you do with higher atmosphere, some uncontrolled dissections may occur, and without any lesion preparation, if you put the stent becomes unexpandable and ultimately leads to the acute stent or subacute stent thrombosis. So that's why lesion preparation is important to prevent the rota regret. And then these RotaPro makes the rotablation very easy because of its user-friendly nature with handy movements. And then the advanced are also very user-friendly with a finger tap. You can start the bar, and finger tap you can stop the bar also with a easy cables. And then there is warning signals also there in the RotaPro, where the burr will stop if the drop rate is below 15,000 RPM, and the open yellow triangle will occur if the RPM drop is below 5,000, and closed yellow triangle will occur if the RPM drops below 10,000. So with these warning signals, you can stop short with the RotaPro in this newer device. And then I will give the two cases of representative cases of my rota experience, how made the complex lesions easy. Case 1 is a 56 years old male with class 3 angina having high risk factors of diabetes and hypertension, and post angiogram patient has left main distal 75% stenosis and a complex bend with ostial 90% eccentric stenosis with heavily calcium with good LV function. So here we want to do good lesion modification, and where the patient has left coronary, you can see the non-dominant circumflex and type 3 LAD with a distal 75% of the lesion with a complex bent ostial lesion with eccentric calcium, and anomalous RCA with intermediate lesion. And then as we are a dedicated CTO operators, the whisper wire, we crossed these bends and calcium with the help of the microcatheter Corsair, and then we exchanged with the rota floppy wire, and then rotablation was done with RotaPro 1.5 bar. Almost 5 cycles we repeated, five runs we repeated, and then we exchanged the rota wire with a Workhorse 0.014 wire. And next, subsequently, the circumflex wire and pre-dilatation was done with 2.5 to 10 millimeters balloon as a part of lesion preparation. And then subsequently, we deployed the Synergy 4 into 24 millimeters provisional from left main to LAD crossover stenting across the circumflex ostium. And this circumflex was well preserved because of the hybrid design of this energy, and then we rewired the circumflex across the stent struts. And then we did the imaging with the intravascular ultrasound, which was shown especially the malposition in the distal left main lesion, and you can observe in this intravascular ultrasound. And then we have taken the 4 balloon in the LAD and 4.5 to 10 NC balloons to the left main, and then optimize the left main stent expansion with a good final result. Then the case 2 is a 90 years nonagenarian patient with a hypertension diabetes having old anterior MI with exertional angina, underwent angioplasty to LAD with a Q waves in V1 to V3, and echo is showing wall motion abnormalities of interventricular septum with a fair LV function, and angio is showing patent LAD stent and with the circumflex distal disease. And now the patient came with angina with RCA showing a Shepard curve with mid segment calcific lesion, Tamtra calcium is there. And you can observe that a patent LAD stent which is type 3, and then circumflex non-dominant diffuse disease, and the right counter you can observe a Shepard RCA with a mid segment heavy calcium, and with AL gave the very good support to the rotablation. Next, we have taken the fielder XTR with Corsair support, and Corsair unable to negotiate. And as the Corval is bulkier, we have taken the Caravel which has a low tip profile of 0.14, and which successfully crossed and rotablation done with Rotapro 1.25. Because of the bends, a scale of 1.5 sometimes may cause the eccentric rotablation with burring with perforation. So that's why we took the undersize to negotiate the bends. And then rotafloppy wire is exchanged to the workhorse wire, that is BMW wire, and predilatation was done with a 3 to 10 millimeters balloon as a part of the adequate preparation of the lesion before stent. Taken 3 to 38 millimeters drug eluting stent with guidegilla support, because a long stent bends even in spite of calcium preparation. Sometimes bends have lot of resistance. We took the guidegilla, and then we did the stent deployment, and after that one guidegilla was advanced into the stent by means of inchworm technique, a guide balloon assisted guide catheter advancement, that is BACA, and then subsequently we did the post-stent dilatation and optimized the stent with a very good final results. So the important message what I want to convey is in a calcific lesion, unless you have a good lesion preparation by atherectomy device like the Rotapro, which the instrument made the user friendly with a handy device with a warning signals, we can prepare the lesion followed by the stent deployment, so that and optimizing with intravascular imaging with IVAS made the job made easy in calcific lesions with a good short as well as long outcomes. Thank you.